Hi, my name is Rosalia Contreras and my topic is necrotizing soft tissue infection. Definition: necrotizing soft tissues infection include necrotizing form of fasciitis, myositis, and cellulitis. These infections are characterized clinical by fulminant tissue destruction, systemic sign of toxicity, and high mortality.
Hello, this is Jacob Avila of 5 Minutes Sono, and today we are going to talk about necrotizing soft tissue infections, or as they're also known as necrotizing fasciitis. Your probe of choice for this examination is going to be the linear transducer. This has the highest frequency and will give you the highest resolution image. Now, there are a few ultrasound findings that you can look for to try and diagnose that NSTI, and that includes thickening of the tissue, deep fluid collections, fascia irregularity, and subcutaneous air. Now, I think most of us think about subcutaneous air with necrotizing soft tissue infections, but you definitely don't need to have air present in order to diagnose this. This is a normal foot. So this is normal subcutaneous tissue, maybe a little bit of muscle down here, some veins, that's these circular things. This is a hyperechoic cortex here with some shadowing. These are the foot bones or the toes. This is pretty bad cellulitis here. If you see this, it should definitely increase your suspicion that this patient may have something else besides just regular old edema. Notice all the pockets of fluid around it. When you have increased fluid collection, it should raise your suspicion of an NSTI. This right here is another foot that has an NSTI, a necrotizing soft tissue infection. So let's pause it and we're going to cycle back to about here. Now there is a lot of subcutaneous thickening here, a lot of thickening. The architecture is all distorted, but look at this right here. This right here is hyperechoic, so it's something that's reflective with a bunch of dirty shadowing behind it. If you see this above where the bone should be, this should raise your suspicion that it is actually air. Air causes this hyperechoic little border here with some shadowing underneath it. Here's an example of increased edema and air. So we have this hypoechoic fluid around these little pockets of subcutaneous tissue. Then we have this very irregular border of hyperechoic something up here. This something is air, with some dirty shadowing underneath it. This is what subcutaneous air looks like, and this is a necrotizing soft tissue infection, or necfash. This is Fournier's gangrene, which is actually the first time that necrotizing soft tissue infections were introduced. Here's a testicle, and if you look right here, this right here almost looks like bone, but you see there's a bit of a mirror artifact out here. This is almost like an A-line. This is a bunch of air inside the tissue of the perineum. This is all a bunch of thickened tissue. This is a necrotizing soft tissue infection as well. Now, it's easy to focus in on the gas, but that's actually a later finding. The other thing to make sure to keep an eye on is the presence of a fluid layer in the deep tissues. And this is what you see here highlighted by all the arrows. This fluid thickness strike is arguably the most important thing to consider when trying to determine if the thing you're looking at is regular cellulitis or an NSTI. This study was a retrospective review of 95 patients, 48 with necfash and 47 with non-necfash or regular cellulitis. And they found that the biggest differentiator was actually this fluid accumulation. This had the best predictive value for figuring out if it was cellulitis or necfash. Now, one thing that you can also do, and this is from that same study, is look at the thickness of that fluid collection. So that's that fluid collection that's just deep to that subcutaneous tissue. And notice as that thickness increased, the specificity and the positive predictive value all increased. So the thicker that you see that fluid stripe deep to the subcutaneous tissue, the more likely it is to be an NSTI rather than just plain old cellulitis. Another thing is that if you see air present, that is very unlikely to be cellulitis. So if you see air with a very thickened stripe, be highly suspicious for a necrotizing soft tissue infection. So to recap, necrotizing soft tissue infections are very similar to cellulitis. They're just like a worse cellulitis. The two big differentiators between the two are going to be air in the subcutaneous tissue and a fluid stripe deep to that subcutaneous tissue. That's it for this week's 5-Minute Sono. Please feel free to send me an email or a tweet, and as always, don't forget.
Application in medicine. Necrotizing soft tissues infection should be suspected in patients with soft tissue infections like edema and signs of systemic illness like fever, hemodynamic instability, in association with crepitus, rapid progressions of clinical manifestation, and/or severe pain. Early recognition of necrotizing infection is critical. Rapid progression to extensive destruction can occur, leading to system toxicity, limb loss, and/or death.
Necrotizing fasciitis. A young patient sustained a small laceration to the leg and was taken to the emergency room 3 days after the injury. The patient had pain, redness, erythema, fever, and low blood pressure. A culture was obtained from the wound to determine the presence and the type of bacteria in the wound. Gram stain showed gram-positive cocci in chains. It was a group A streptococci. Necrotizing fasciitis is also called a flesh-eating bacteria or disease. It is a limb and life-threatening soft tissue infection. Early diagnosis and adequate treatment is important to save the life or the limb of the patient. Usually occur after a minor trauma. It may be associated with chronic diseases or illnesses, usually found in alcoholics, diabetics, after insect bites, or post-surgery. Mortality rate is about 33%. This is published data. It is underdiagnosed because it resembles low-grade cellulitis. Surgical debridement should be urgent. Delay in surgery more than 24 hours is associated with increased mortality. Diagnosis: pain and tenderness beyond the apparent margin of infection is diagnostic and found in about 98% of cases. Group A strep is common, but other polymicrobial infection will start and involve the fascia, and the toxins will spread. Other findings in the diagnosis, and these are published data, include erythema 100%, poly formation less than 50%, crepitus about 14%, skin necrosis about 14%, tachycardia about 75%, fever 50%, low blood pressure, hypotension, or we call it septic shock, is not very common. It's about 18%. Treatment. Early diagnosis is important. Aggressive and extensive debridement of the affected area. Always obtain a biopsy from the periphery and not from the necrotic center. Debridement should be repeated on almost daily basis. Give antibiotics according to the culture and sensitivity. You can use hyperbaric oxygen. Usually there is good result for coccidial infections. There is a high incidence of extremity amputation if the fascia is penetrated by the infection. Case examples: patient number 1. Here is a necrotizing fasciitis involving the volar aspect of the arm and forearm. You can see the hand is also involved, so as the dorsal aspect of the elbow. You can see the function after debridement and skin grafts.
Pros and cons. Pros. The diagnosis of necrotizing infection is established by surgical exploration of the soft tissues in the operating room, with physical examination of the skin, subcutaneous tissues, facial planes, and muscle. Cons. Risk factors for death include age, female gender, extent of infection, delay in first disbursement, elevated serum creatinine level, elevated blood lactate level, and rate of organ system diffusion and admission.
According to the Centers for Disease Control and Prevention, necrotizing fasciitis is a serious bacterial infection that spreads quickly and kills the body's soft tissue. People with flesh-eating bacteria usually begin to display symptoms within a couple of hours after an injury. Symptoms may seem like another injury or illness. Some people complain of a pulled muscle like pain or soreness. The skin may also get warm and form red or purplish areas of inflammation that rapidly spread. Later symptoms can include fever, chills, fatigue, and vomiting.
Issues apply in Ecuador. In Ecuador, the most common site of origin of infection are the perineum, fournier disease, and the foot in diabetics. In general, impaired antibiotic treatment of necrotizing infection should consist of broad-spectrum antimicrobial therapy, including activity against gram-positive, gram-negative, and anaerobic organisms. Conclusion: necrotizing soft tissue infection represents a group of highly lethal infections best treated by early and repeat extensive dispersion and broad-spectrum antibiotics. Hyperbaric oxygen appears to offer the advantage of early wound closure. Certain markers predict those individuals increased risk for multiple organ failure and death, and therefore assist in designating allocation of intensive care resources.
Necrotizing fasciitis is a surgical emergency that is difficult to recognize in the early stages. Can be classified according to the causative organism. Type 1 is caused by mixed aerobes and anaerobes, often occurs post-surgery in diabetic patients. Type 2 is caused by group A beta hemolytic Streptococcus pyogenes. Features: acute onset, painful, erythematous lesion develops, extremely tender over infected tissue. Management: urgent surgical debridement, IV antibiotics, clindamycin and benzopenicillin. A 46-year-old man presents to the emergency department due to severe pain in the perineal area over the past 6 hours. On examination, the skin is cellulitic, extremely tender, and hemorrhagic bullae are seen. What is the most appropriate management? Answer: urgent surgical debridement. Surgical referral is the single most important step in the management of necrotizing fasciitis. There has been little change in the mortality of necrotizing fasciitis since the introduction of antibiotics. Thank you for watching.